I'm Diana Rauner, for the President of the Ounce, and it's my privilege and pleasure to welcome you to our communal home visiting party for the nation. It's so wonderful to have the opportunity to get together and see each other, see old friends, make new friends, learn together and think together, and to share ideas, innovations, and the just incredible growing excitement about the importance and possibility and potential of home visiting. So thank you for being here. We are thrilled to have you here, and we hope that you are going to learn and enjoy a tremendous amount. Before we do anything else, I want to give a huge shout out to the many, many people here who have spent a tremendous amount of time working hard to make us all enjoy this. I want to start, of course, with our steering committee. Thank you very much to the field leaders who've helped us out here. And I really want to give a shout out to the very many employees from the Ounce and everywhere else who've been helping to make sure that all of our needs are met and everything goes smoothly. Please join me in a round of applause for our team. So yesterday, over 300 people joined in our collective Communities of Practice event, which is really exciting, to talk about policy and advocacy, professional development, and our newest community of practice on network weaving. And very, very exciting to have that level of shared knowledge and learning. When we started these communities of practice a few years ago, we weren't sure if anybody really wanted to do them, but boy, people really do, and that's great. Each community really is an opportunity to create a national forum and exchange ideas, innovations, and lessons learned. And learning from each other is really what is so exciting about this event. I'd also like to thank our sponsors of this event, the Heising-Simons Foundation, and the Pritzker Children's Initiative for supporting the communities of practice. And now, I'm going to hand it over to Kelly Woodlock, our Vice President of Home Visiting, whose commitment, leadership, and support makes this really go. So thank you, Kelly.
Good morning. We are excited to get this party started, but I have about 3 pages of housekeeping that I need to talk with you about before we get started. I want to reiterate our thanks to our funders, Heising-Simons and Pritzker Children's Foundation Initiative, for their continued support. I'm going to do a little more than thank our steering committee members. I'd actually like you to stand up, please. Could our steering committee members please rise? We want to give you a round of applause. Thank you. Your guidance through the process of summit development and being here today is really, really much appreciated. I also want to thank the 90+ speakers and poster presenters that are with us throughout the next few days. I won't make you all stand up, but we'd like to thank you as well for your time and energy. Over the next 2 days, we will engage with peers from across the country and the world as we learn together and broaden our knowledge. You can see some highlights up here that we will have 28 workshop sessions and 4 amazing plenary sessions this year. So we're really looking forward to that. Yesterday, some of you may have attended one of the communities of practice. You may have done some Capitol Hill visits. And of course, we had our poster session and reception last night in which there was a really nice turnout, and it was wonderful to have a moment to just relax and talk about the work together. So thank you for attending. This year is our 2nd consecutive year that we will be live streaming our plenary sessions, free of charge to the field. So all 4 will be live streamed. And this will be our largest summit to date. So with over 750 live attendees and another 700 on live stream, we expect to reach 1,300 or so people. So thank you again for your choosing to be with us. We did our best to accommodate registered attendees for each of the sessions. And we had really nice pre-registration involvement, so thank you for that. We encourage you to attend the sessions you registered for, just to help with our meeting capacity. If you didn't pre-register or need assistance in registering for sessions, please see one of our team members at the registration desk. They would be happy to help you. How many of you downloaded the app? Maybe I should ask who hasn't. Wow, great. If you haven't, you will want to do this. It's fairly, if I can do it, trust me, you can do it. I'm having trouble with the clicker, so if I can download the app, you can download the app. Oops, now I get to try my back button because that didn't work. Right, there we go. You'll want to go in and download the app because there are some features again this year that will be useful to you in your sessions. We will have live polling again in some of our sessions for workshops and possibly here in the plenary sessions. And there will be opportunities to complete surveys after each of your sessions, and we highly recommend that you do that. And to even entice you more, the top 3 users of the mobile app will receive a $100 Amazon gift card. So if that's not enough, I don't know. Okay, so you can post to social media and get points. You can view your session content and get points. You can reach out to some other colleagues and text them and get points. I mean, it's endless. It's $100, people, so get busy. All right. Like I said, if you need help, please go out to the front desk. This year, how many of you were here last year? Okay, so a fair amount. We have 44% of our audience this year are new attendees, so that is really amazing. So it's nice to have new folks. For those of you who were here last year, you might remember that in lieu of a gift, another water bottle that sits in your cabinet or a bag that you give away, we worked with a local organization to put together hygiene kits, and then we gave them to an organization that helps the homeless in DC. This year, we're doing something a little different. How many of you had your little people when you registered? Okay. This year, you have a choice to take your little person and put it in one of the jars for one of the 3 organizations listed here. At the end of the summit, we will donate those funds to each of those organizations with an accumulation of about $3,700 going to these organizations. So thank you very much for your choices. All right, I think I'm almost done, but before we get to our amazing plenary session, I also wanted to remind you that directly following this plenary, we will have a federal update on the McVie landscape and home visiting as it stands. So please stay seated after the plenary for another 15 minutes or so to receive this really vital information. All right. So now let's get to the real deal here. We are really honored and proud to have Dr. Joia Crear-Perry join us this morning as our kickoff plenary speaker. Dr. Joia, I can call you Dr. Joia, okay. Dr. Joia is the founder and president of the National Birth Equity Collaborative. She is a global maternal health advocate, recently addressing the Office of the United Nations High Commissioner for Human Rights. Previously, she served as the executive director of the Birthing Project, director of Women's and Children's Services at Jefferson Community Healthcare Center, and as the director of clinical services for the City of New Orleans Health Department, where she worked to improve access to and availability to affordable health care to New Orleans residents following the Hurricane Katrina disaster of 2005. And in this role, she was responsible for 4 facilities that included WIC, Nurse Family Partnership Home Visiting, and some McVie interactions as well. Dr. Crear-Perry completed her medical degree at Louisiana State University and her residency in obstetrics and gynecology at Tulane School of Medicine. She was also recognized as a fellow of the American College of Obstetrics and Gynecology. Her love is her family, health equity is her passion, and maternal and child health are her calling. So please join me in welcoming Dr. Crear-Perry.
Great, you didn't forget anything. Clicker. All right, good morning, y'all. How y'all feeling? This is early for me, so I'm trying to get myself together. I have my coffee, Hopefully we won't mess up too many things. Once I stopped delivering babies, I scheduled nothing before 10 a.m. When you spend your entire life having no control of your schedule, you're like, you know what? I'm sleeping in. Even if I'm just awake, I just lay in bed till 10 because I can. All right, so we're going to try to go through in about 45 minutes what we normally take 2 days to train people on. So, y'all are brilliant. I think you can get it in 45 minutes, but if you don't, know that there's an opportunity to continue learning because this is something we're all continuing to learn and to, as my grandmother would say, to unlearn, right? Because so many things that we've been taught were incorrect. So just really thinking about how we have to unlearn so many of the things that we were taught in nursing school and medical school and social work and how those things are really impacting how we care and provide care for patients today. So if you remember nothing else I say, remember this: the reason that we have inequities based upon race, gender, or class are not because people are making bad choices or they have different genes. It's because of policies. We create policies that value people differently based upon race, class, and gender. So all of you in here are policymakers, right? You vote, that makes you a policymaker. So we can undo the things that we have done through policy that cause inequities together. So that's the whole talk. Okay, no, it's good. So here we go. All right, so our organization is about 5 years old. We started with some funding from the Kellogg Foundation to work on Black infant mortality, and although I'm a 48-year-old Black woman who's living in a 48-year-old Black woman's body, we did not have maternal in our mission. Like you, we focused mostly, and most people, on babies. As if the wrapper, as my great friend Allison Stubbe would say, you throw away the wrapper and the wrapper has the baby, you throw the wrapper away, right? So about 6 months into our organization, we were invited to the Mother House in Atlanta with Sister Song to talk about this fact that Black women were dying at 3 to 4 times the rate of their white counterparts. So we added maternal to our mission and to our vision. Recently, we relooked at our mission, vision, and values, and today the value I want to uplift is sisterhood. Because if it weren't for my sister Kay, I probably wouldn't be here today, so I want to thank you. All right. And then the clicker stops. No, here we go. So Dr. Art James is one of my favorite mentors, and he talks about this connection of both clinical and social, and that's really what we do at MBEC, try to look at both the clinical parts of work that we provide as an OBGYN or inside of the work we do in healthcare, but also with the social. And that's where the alignment around centering pregnancy, McVie, home visiting, Healthy Start, all the importance of all those things coming together for us to be able to provide care. Where should I be pointing? So this is why, you've probably seen this slide before, this is why I get to travel around the world, because as I mentioned, the United States is the only industrialized nation where maternal deaths are going up. They just released a new thing today. I saw Dr. Phipps released a statement where she said the word racism from ACOG. I was like, all right, come through ACOG. So yeah, we're the only industrialized nation where it's going up, and Black women are dying at 3 to 4 times the rate of their white counterparts. And this is despite spending more than any other nation on health. So all the other countries that have better outcomes than we do, they're on this same slide, they're just lower when it comes to spending. They spend a lot more money on things like home visiting. I know y'all are surprised by that, not? Okay. So think about how we structure our systems and structures in the United States, and then we say, well, why do we have such bad outcomes? And we see countries that have better, and they do things like invest in people where they are and provide them services in their homes and not make them come downtown to the medical center just to have care, right? So one of the, and what these countries have in common is they have a human rights framework. So this is a list of the countries that have better capital when it comes to human rights, and they're the same countries that have spent less money on healthcare. They're also the same countries that have better maternal health outcomes. You see a trend? Yeah, okay. So when you have a human rights framework, you believe that all people should be able to live to their full potential, no matter race, religion, class, that everybody innately is valuable and should be able to live to their full potential. So the countries that have a human rights framework do things like free college, free childcare, free paternity leave. I was just on the Hill Friday, 2 days ago, begging for just paid leave for a couple of weeks after you have a baby, right? They have paid leave for the father even. And so this investment in social structure gets you to better health outcomes. And as an OBGYN, we know that. We know that when sitting in front of you for 10 or 15 minutes is not going to manage all the other things that are happening in your life, right? That this clinical relationship around your blood pressure has very little to do with your lack of access to healthy food, right? And so why don't we have a human rights framework in this country? What are the barriers to us believing that all people should be able to live to their full potential? Well, this is another Art James slide. And it's an important one, because we need to realize that 87% of the Black experience in the United States has been under direct federal policy-approved legal oppression, right? That we've only been able to have basic civil rights for the last 52 years, and we're still fighting within this 52 years to be seen as fully human, right? So that impacts all of the ways that our policies are created, who has decided who should have home visiting or not, right? We know that in 1960, both women and Black people are still fighting to be seen as fully human. Women, white women, had to have permission of their husbands to buy birth control in 1960, right? So we're all trying to get civil liberties or civil rights, but none of us have had a human right. So it's important for us to hold that in mind, and when we think about how are we going to move forward as a country and as a nation, and under what worldview do we really believe that we all should have access to better outcomes? So who's heard of reproductive justice? Our RJ people now? All right, we got a few, yay. So yeah, I'm a dissident OBGYN, and I like to hang out with the RJ folks. So about 25 years ago, right after the meeting in Cairo, some Black women, during the first iteration of healthcare reform under the Clintons, there was a lot of conversation around reproductive rights, right? It was an exciting time that we would be able to expand access to birth control and contraception, and women would have choice around their bodies. And that same language you still hear a lot today. But for Black women, that never quite fully resonated, right? Like, it's not just my ability to have access to birth control. If I am worried like I am today, I have a 9-year-old son, I do not allow him to play in the park alone with a toy gun, right? For a Black mother, we worry about outliving our children. So our reproduction is not tied to birth control or access to a clinic. It's all these other things. So the first tenet of reproductive justice is personal bodily autonomy. That means if I don't want to lark, I don't want to lark. You can't make me want to lark. It's my body, my choice. You don't get decision-making over my body. It also means the ability to have children. Did you know, in the UK, those countries that have better outcomes than us, they provide free in vitro fertilization on public insurance for 3 rounds all across Europe. We don't even have that on people's insurance for your jobs, right? So we have privileged the ability to have children to the wealthy, as if being rich makes you a good parent. Everybody in this room knows that is not a truth, right? I know some rich people who should have never been anybody's mama. We are all clear on that, right? So this idea that wealth makes you a good parent is a very uniquely American idea, right? So what would it look like if we believed everybody? We can't even get on public insurance. You can't even come in and get to see if your tubes are blocked. We won't even pay for that, much less in vitro. Like, it's a shocking idea. The ability to not have children. And who's in a state that did not expand Medicaid? There we go. All right, so I'm from the great state of Louisiana. We did not up until we got a new governor, yay. But up until then, you only qualified for Medicaid if you had birthed a baby, right? You had to be a mother. So we tied even your ability to get insurance to your uterus and it birthing something. Like, doesn't that sound odd to y'all? Like, people just, if you never have children, you don't ever get health insurance because you're not important? You're just working, flipping somebody's bed in the hotel, making minimum wage, and you don't get access to health insurance? We would never choose that, right? And then the last one, parenting my children in safe and sustainable communities. That's where you really talk about, my son being not able to play in the park. I live in a very safe community, but it's not safe for him, right? So how do we ensure that you worry just as much about my son as I worry about yours? And that we put in systems to ensure that all of our children get to live their full potential. So that means if I show up at your pro-choice rally, you come to my Black Lives Matter rally, because both of those systems and structures are tied to each other. It's important for us to understand that oppressions are tied to each other. We have to work together. So the use of birth control has become a right or an option for white women, while it's become viewed as a necessary obligation for poor women, particularly women of color. So this is a quote about LARCs and IUDs. But we could say the same thing about home visiting. So you have to think about that when you do your work. Who do you see when you're thinking about home visiting? Do you believe that everybody should have access to home visiting? And if you believe that, then why do we say it's only certain people that we can look at and tell they need it or not? You know, if you can't say amen, say ouch. Okay, that's what my pastor would say. All right, so when we started our organization, we did not have a definition for birth equity. We had definitions for equity in general, health equity. And so we looked at those definitions and said, what for us resonates with our mission, vision, values? So it's the assurances of the conditions of optimal birth. So not just, we're not going to get to this place where everybody's equal, we can hold hands, there'll be no more fighting and saying kumbaya, right? We all know that the same people who are hoarding, I said what I said, power and wealth today, are teaching their grandchildren to hoard power and wealth, right? So if we want to assure equity, we have to teach our grandchildren about justice and equality and fairness. So that's our job. So the assurances, the policies, big P, policy, little p, of the conditions for optimal birth. So we want to thrive. We don't want to just survive childbirth. We don't want people like, oh, thank God I made it out of the hospital, right? We want folks to thrive. And we have to be willing to address both racial and social inequalities in a sustained effort. So there's a difference. You all measure a lot of things. I know you do, because I'm a part of public health, and we measure everything. And you're researchers, and we're policymakers, and we're measuring, right? So these are indicators. And indicators are a measurement, they're limited by our current reality. They're a product of our past understanding of public health and science. And systems are more apt to adhere to specific prescribed indicators than to determine alternatives. If I go to another meeting about pregnancy intention, I might stab myself in the eye. Right? We track it for everything, and it don't track for nothing, but we keep tracking it. And we're so stuck to it. You know, it's only 50 years old. We can pick other measures. We can. I promise you, it won't kill us. All right? So if you think about under what framework did we even pick this as a measure? So a framework is a vision. It expands our understanding of current reality. It allows freedom to explore language like reproductive justice and birth equity. It explores alternatives to traditional data collection and application, and it questions historical constructions of health systems, which all of you should do because you're part of. It's really important for us to think about that. So we don't have to pick intention, although, you know, asking people to have middle-class values without middle-class money, it's not very smart. I intend to run a marathon. That requires me to actually exercise at some point, which I don't do, right? But we like that intention. So we can pick another one. We can pick marital status. I love my husband. Marry him. He's great, awesome. He's super cute. Me marrying him had nothing to do with my maternal and child outcomes, okay? So marriage is a proxy for wealth. Turns out when Black people have been denied wealth for generations, us getting married to each other doesn't really help our outcomes. If we want to measure wealth, right? If you're wanting people just to be married, say that. Don't pretend that you're just putting in your data for no reason, right? So both human rights, reproductive justice, and birth equity, all three of those are frameworks. That if you're visioning for those frameworks, then what are the measures, what are the indicators that you would measure to get to those things? So we talk a lot in meetings about replacing pregnancy intention with pregnancy well-being. And why that should matter to you is if we really wanted all people to have well-being when they are pregnant, they should have access to home visiting. It's not even that hard to think about. It's really an easy stop. You can get one. If you don't need any more, you don't need any more. But truly to understand because then you could do a well-being check. You could figure out what the other needs are. You can see the rich lady who's been taking the Xanax, who's not even paying attention to her child, that nobody acts exists, that we all know exists, right? So really thinking about bigger, instead of trying to put people in boxes, if we all agreed, we all have value, and we all deserve to have well-being, what kind of system and structure would we build? And how do you use your collective power? I'm looking forward to this federal conversation around what that would look like for you. So root causes. Am I already 44 minutes in? I can't be 44 minutes in. That's together, us combined. Okay. Like, geez, I know I was rambling. All right, so. Okay, so the root causes. So when I was the health director in New Orleans, I was a young person in the room, in a big room like this, and 2005, so you know what was happening, right? 2005, New Orleans, yes. So the president flew by. He waved at us. Y'all remember that? Yeah, I was there. But one of the other exciting things is the World Health Organization came. They actually came and they sat in a room like this, and really smart people, Dr. Satcher and others, they talked about this idea of social determinants of health. This was mind-blowing, right? 2005, this is a transformational moment that we go from saying that it's patients' genes or their genetics or their choices that have us to have inequities, but it's things like a living wage. Shocking. Access to healthy food. Who knew? Right? The boys are like, me, I've been saying this for 100 years. Anyway, so yes, this was exciting for WHO to lean in, and that these things cause unhealthy behaviors, which cause a disparity in disease. So this is super exciting, that we have moved away from blaming and shaming individuals, but looking at social determinants of health inequities for outcomes. So we have childhood obesity, not because children just like Chewies, although I like Chewies. We have childhood obesity because we have lack of access to healthy fruits and vegetables. We took out PE in school, blah, 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 right? On and on and on, right? So, but you see the top of my slide is still empty, because the conversation we have not had since 2005 is, where did these social determinants come from, right? I love being black. Been black all my life. Have grown up around all black people. But I didn't happen to move into neighborhoods with black people because it's tribal. That's not how that works, right? We have laws and power that have created those systems, okay? People come up to me afterwards and say, but you know, it is tribal. No, it's not. Okay, so above these social determinants, we have a power and wealth imbalance. And those are things like our tax policies, deregulation, the globalization. So I'm gonna give you an example of a tax policy. I mentioned I'm from New Orleans. My whole kind of centering of my life is New Orleans. I'm cold today. I know y'all think it's warm right now. It's not. So, I got my big coat. So in New Orleans, after Katrina, there was a lot of disaster money, and people came down and they tore down people's homes and built mixed income housing, right? And they get a tax credit if at least 7% in the housing is low income. So they tear down thousands of houses where low income families lived, build a condo complex, and they have to put 7% of them low income, and guess what? They get a tax credit, and they only have to stay there for 10 years. So what do you think happened in 2015? They kicked all the poor people out, right? So that is a power and wealth, that's a tax policy choice that none of us would make, right? That would not be fair. Why would you say you get to make money, keep tax money, and kick the poor people out? Good Lord. How much more do you need? And that happens around the country over and over and over again. In the US, it has three main root causes, which are racism, classism, and gender oppression. You can add some more. You can add, in my state, all day long, religious fundamentalism. That's a whole other conversation. You can add, in other contexts, tribalism. You could add casteism. You can add some more. We're going to at least stick to these three to start. And until we work on these three, what we will do is keep making programs for the social determinants of health, like finding new ways to get small amounts of home visiting, versus undoing why we believe we can tell by looking at somebody if they need it or not. So social determinants of health are the conditions in which people are born, grow, live, work, and age. So this is the part most of y'all can quote, but you skip the second sentence, like the preamble to the Constitution. There's a second sentence that said, these circumstances are shaped by the distribution of money, power, and resources at the global, national, and local levels, right? So all of us together are subject to that. Your careers, your lives, your jobs are formed by these circumstances that are about money, power, and resources. So let's talk a little bit about race. That's what I do. So race is not an ethnic group. It's not a population. It does not equal ancestry. So when I was in medical school in 1997, which in my mind is not that long ago, my daughter would say, Mama, you're super old, get over it, but I'm still holding on. So my embryology teacher said there were three races: Mongoloid, Caucasoid, and Negroid, right? So we've been teaching in medicine, in nursing, and public health this belief of a biological basis for race for hundreds of years. This is not a new idea. So really the new idea is that that was not true. We've spent so much money. The Tuskegee Project was not just people being mean. They were trying to prove that black men's brains were attacked by syphilis different than white men. We've been trying to prove through science, through research, through bodies like this, the difference between the races for a very long time. right? So there is no genetic or biological basis for race. It's a social and political construct. So that means the policies and the things that you do, you get different outcomes if you believe that people are different based upon the color of their skin. A belief in a hierarchy of human value based upon skin color has been killing us for about 500 years. It's time to let it go, because it's harming all of us. You might get a higher peg, but you're still at a peg. So race is the physical differences that groups and cultures consider socially significant. Ethnicity refers to a shared culture such as language and ancestry. Race is real and it matters in society, but not how racists think it does. Like I said, I'm black, gonna die black, love being black, but it's not in my genes, right? It's not in my culture. I grew up in New Orleans where there are people who one sister would marry a white man, one sister would marry a black man, they raised their kids as black and white. If it was biological, we would have had to let that go a long time ago in New Orleans, let me just trust you. Because people are living their lives, representing themselves as one or the other. So that's when they check off their race, it's based upon their own belief of what they are, not what you perceive them to be. Race is a self-identification marker. Okay. Race is not biology, but racism has biological impacts. So we have about 20 years of data signed to keep more and more data, showing all kinds of stuff. We'll go over some of it now. This is a video that we're not gonna do because I'm long-winded. But it's a video, you can look it up on YouTube. It's called The Story of Race, it's a PBS, it's great, it's about 8 minutes long. And it goes through how we even got these constructions in the first place. It talks about the census, and it's a really good overview that we don't learn in school. I really feel like the only reason I'm doing these talks is because our books don't put these realities in them yet. Okay, so it's racism, not race. We have different outcomes for people of color, for black people, because you believe we should be different, not because there is anything different about us. So that means we have to have a conversation what the term racism means. It's not a slur. We can relax our shoulders. I'm not calling you a bad word. I'm not saying that you're a bad person. There is a belief of a hierarchy of human value based upon race, and it goes across our structures. So these are the definitions given to us by Dr. Kamara Jones, who past president of the APHA, who talks about the different levels as institutionalized, personally mediated, and internalized. So when I say the word racism, what you hear is the personally mediated one. So that is the biases and differential assumptions about the abilities, motives, and intentions of others by race. So that's the tiki torch, right? You're being mean to me, you're calling me a bad word, which does happen. Some of you all have seen it. I don't want to act as if that does not exist in health or in public health or in home visiting, but it's a small part of why we have these larger issues in our health system and our health outcomes. Institutionalized are the structures, policies, practices, norms resulting in differential access to the goods, services, and opportunities of societies by race. So I've mentioned home visiting a few times because y'all know that one. I'll give you another concrete one. Medicare and Medicaid. Where were we as a country when they were founded in 1965? A little bit further back than we are today, right, when it comes to race. So for the Southern senators to vote yes to a benefit for poor people who they perceive to be black people, right? So they've racialized a public health benefit. They said, we have to control that. So we control Medicaid. But Medicare, which is something you get after you retire, was seen to be for white people, so much so that the original folks who were not included in Medicare were farmers and homemakers. And who were farmers and homemakers in 1965? Black people, right? So this idea that we can't undo the policies that we've done, you have to use race-neutral policies to undo racist things that we put in the first place is illogical. We weren't race-neutral when we created Medicare and Medicaid. Right? And so we're seeing the outcomes of that even still today. And then internalized is the one that people, black folks know, that this idea that we've been living in a place, in a world that doesn't value us, we've also internalized that belief as well. So we do things like not want to live near other black people, and racism just finds us when we live in the gated community. It just follows us, all right? And so also, Kamara did a talk. She's usually the big keynote. I'm like moving up in the world. She's the big keynote, and I'm the afternoon delight. So back in 2017, she gave a talk, and she added to the definition and verbally, and I told her I'm going to add it to my slides because she said it. But it's the stigmatized and non-stigmatized group. So for those who are not black, to believe that you're supposed to have things based upon being not black, right? So it makes you do things like vote against Obamacare when you actually need Medicaid in your state for substance abuse, right? So that whole racialization is harming all of us. And once the reason that is so important to the rest of anything else you all do is if you still believe that the reason you see different outcomes is because there's something innately wrong with us, when we start talking about ending inequities or ending disparities, all you hear is blah, blah, blah. So we have to have a core understanding that the reason that they exist is not because the people are broken. And so when you look at the data, you can see that Black women who are college educated have worse outcomes than all other races who never finish high school. This is when we unpack the data. Because when we saw that Black women were dying at 3 to 4 times the rate of their white counterparts, we were like, oh my God, they're gonna blame us again, right? Your babies die twice as much, you have twice as much hypertension, now it's 3 to 4 times, here we go. Y'all are so fat, you don't listen, you never show up to the doctor, you're so non-compliant, as if all white women are skinny and do everything that people say. Every time I hear that, I'm always like, have y'all met white women? Because I have. And trust me, they are not trying to follow all y'all's instructions. I don't know who these white women are that y'all are talking about, and we're non-compliant. Okay. Anyway, and then for my OBGYN colleagues, the hardest part is that even Black women who initiate prenatal care in the first trimester still have worse outcomes, maternal child health outcomes, than white women who have late or no prenatal care. So this doesn't mean we shouldn't exercise and we shouldn't go to school and we shouldn't go to the doctor. But even when we do all of those things, we're still more likely to have poor outcomes. And since we know we're not genetically different, then we have to look at, well, what's causing it? What are we going to do different about the system and the structures and how we treat people of color that causes them harm despite them doing all of those things? Where does our role on the other end? We have enough organizations that are telling people of color what to do. Thank you. What are we doing on the other side to make sure that we are fixing, that we are not assuming that they're not going to listen and they're not complying and they're all obese and it doesn't matter? So these are some of those studies that we've had for the last 20 years. This is showing that maternal stress increases your telomere length. We have biological data that shows racism is real. It causes your body to change, right? Life stresses cause your accelerated telomere shortening. Worry about racial discrimination. This is from UCSF, from Dr. Braveman, a missing piece in the puzzle of Black-white disparities. Just think, the more you worry about racism, the more it's impacting your day-to-day life, the more likely you are to have a preterm birth. So instead of looking for a pill or a shot or some more progesterone, why don't we stop making people worry about racism? What a shocking idea. So great. So we did some interviews. This is the Campaign for Black Babies, which we originally funded for through the Kellogg Foundation. We interviewed Black women across the United States about who had had an infant death and to tell us their experience. And we created a birth equity index. We looked at about 50 different social determinants of health to see which ones had a positive predictive value for infant mortality. About 10 of them came out. Some things you would guess, like obesity and smoking. Some you might not, like the level of pollution in an area. You could actually go to your communities and say, instead of just telling people a lone back crib, how about getting rid of this plant that's putting all this pollution into our communities, right? These are the cities across the United States that have the most Black births, infant deaths. The cities in red are where we interviewed. The worst is in South Carolina, and the best is in San Diego. So I don't know if we should all just move to San Diego or is that bad? I think I have these twice. Good. All right, so if there is Black, that means there is white. Yes, there is no Caucasian. There were no Caucasus Mountains. That is not a medical term, right? So race is a social political construct, so Black is a social political construct, so is white. So this is an article. David Williams is the third author. He's at Harvard. He's a pretty fancy guy who talks about racism. In my mind, we're friends because I've met him a few times, so I always bring him up. But they looked at, there's books, there's censors, there's whole entire institutes around Blackness and health. What y'all got for whiteness and health? Nothing, right? So then how do we start thinking about what is the impact of whiteness on health? So the concept of whiteness is the system that socially, economically, and ideologically benefits European descendants. This is the article if y'all want to look it up. The effect of whiteness on the health of whites. And I'm sure there's a bunch of epidemiologists in here. What they did was create a framework. It starts with capitalism and goes all the way to morbidity, mortality, and mental health. In residency and medical school, I was taught that white men are 12 times more likely to commit suicide than black women. We are not looking for the gene for white men and suicide. We say, well, they're stressed. They got a lot of work. There's all these stressors on their jobs. It's a lot happening. And that's all true. It's also true for black people too, right? And if you think about when they went through this study, what they found is that, and for white men specifically, there was not a redemptive narrative. I did a panel with a Latina sister and a Native sister, and we talked about that in communities of color, we have to believe we gonna be all right? We have a whole thing around the sun will rise tomorrow, challenges will happen, you will be okay. Where is that ability in that lane for white men? Where do we make room for them to fail, right? Where is the redemptive narrative that it's okay, that you don't have to be in charge of everything? We don't. So whiteness is killing, or the belief in a hierarchy of human value is killing all of us. The belief that people are different and should have different roles based upon their skin color is not helping any of us. And it shows up in the data. This is infant mortality by race. This is blacks. Yep. In 2016, I really need glasses. So I usually say the South and the Rust Belt is usually the worst areas. And for whites, it's the same areas. They're just doing better than black people in those areas, but they're still doing bad. Because when you disinvest in education, housing, transportation, it hurts everybody. It just disproportionately doesn't hurt white people as much. So a white person in Atlanta, Georgia has an infant mortality rate of about 6 per 1,000, whereas a black person has an infant mortality rate of 13 per 1,000. So great, they're doing great. But a white person in Oregon has an infant mortality of 1 per 1,000. So there's not a genetic difference between white folks in Atlanta versus Oregon, but they've got a lot more home visiting, a lot more doulas, a lot more midwives. They have a lot more infrastructure. They have paid leave. They've created all kind of infrastructure in Oregon that we do not have in a state like Georgia that does not even want to do Medicaid expansion. So you get disparate outcomes based upon policy solutions that are then devaluing groups of people and using each other to pit each other against each other to not create a policy agenda that everyone actually all needs. Everybody in Georgia needs access to some insurance and home visiting, for sure. So I, as a physician, have to talk a lot to my colleague physicians around our role in power and authority. And you all have a lot of power as well. You're going into people's homes, you're making policies around people's homes, so really, you have power. So you have to understand the levels of power. So there's 3 different levels. I'm a fake community organizer. I'm an OBGYN who wants to be a community organizer, see? So when you do community organizing, you have to understand power. Like, I know y'all do a lot of collective, what is it called? Collective impact model, there you go. It's hard to do collective impact when everybody has different power. But people love talking about collective impact. So we have to understand the difference in power levels. If I'm a community member and you are the CEO of the hospital, there's no collective in that impact. Right? Somebody has to normalize the power structures. Okay. So power has 3 dimensions: worldview, agenda, and decisions. The dominant worldview in the United States has been survival of the fittest. Go out west, young man. We only need to do home visitings to certain people. You like that? I threw that in there. So that creates an agenda which creates decisions around policies, right? So what if the normative or the worldview for the United States was the least of these is as important? How different of an agenda and how different of policies would we make as a country? And that's really where you can feel the tension a little bit as our worldview is kind of shifting from go out west, young man. I can feel it when I testify before Congress, the tension between that worldview and the worldview of the least of these is as important. And they're both really important ideas. Neither one is bad. They're just very different worldviews. And the power dynamic comes between who has the power and their worldview is the dominant worldview for the work that you're all doing and the world that we all live in. And my favorite book is Ibram Kendi's Stamped from the Beginning, The History of Racist Ideas in America. And he talks about, people ask him, what came first, racist ideas or racist policies? And he would say people use racist ideas for their own power. So politicians use it to get more political power, capitalists use it to get more money, people like me use it to get more speaking engagements and hopefully force the good, right? And so what we have, though, versus their individual power is collective power. We have collective accountability. We just have to have honest conversations of how we got here, right? So one of those is knowing that we've always had Black institutions that worked on public health. This is not a new thing. right? So we've provided health services through National Negro Health Week. I brought up Du Bois earlier. We had the medical civil rights movement. And we also have a history of reproductive injustice. We don't teach our medical students and residents the history of OBGYN and the history of Dr. Cartwright, who at my institution of Tulane created a disease called drapetomania, that if a slave looked you in the eye, you could give him more lashes. This is in medical textbooks. If a slave tried to escape, the treatment was, because he was clearly mentally ill if he wanted to escape slavery, is that you could cut off a toe, right? So this idea that all health is good and it's exciting to have people come to your house because they're here to help you, Black folks don't have that history and legacy to lean on, right? So we have a history of being policed, being violated, and so that desire to come in our homes to help us, you have to think about what we are hearing when you say that and what history we are coming from. And the Black midwifery, granny midwifery, is another example of the places that we have demonized things because the people were Black. We're the only industrialized nation that doesn't have a midwifery workforce. And we have to ask ourselves why. So back when I was a resident in the late 90s, early 2000s, we didn't have a disease. It was just called crack babies, right? Crack babies and crack mamas. Illicit drug use was thought to be more in Black women, even though it's equivalent. They were considered to be biologically inferior. We had people high up in government saying they were going to be eventual super predators. They would get data from people like you to say things like that, right? So one of your peers wrote a research and said, oh, crack is going to cause super predators. And next thing you know, politicians repeat it. I know, because they repeat what I say now, so trust me. I'm clear that that's what they do, okay? Pregnant drug users were convicted as killers. Some of them are still in jail today, right? People who were substance abusing are now in jail as murderers. Okay? And there was mass incarceration. Think of the narrative we have today around opioids, right? Opioids are America's mothers and daughters. It's an epidemic of despair. There's been a public health response in this administration of at least $45 billion. If I go to another meeting about opioids, I'm gonna pull my hair out again. But it's important for us to think about, it's not that this is not important, it's exciting. We need people to soften their ideas around substance abuse. But if we had not racialized crack addiction 20 years ago, we wouldn't be here today for opioids. We would have created a system around substance abuse 20 years ago. So when are we going to learn the lesson of not replicating that idea over and over again and feeling at least on one peg up higher? Because that peg is going to catch up with you. So when you do work without actually talking to the community, you do things like create crack babies. So the data, Dr. Claire Cole shows that people don't have long-term impacts. Some of the people who were considered to be crack babies are now lawyers and judges and all these other things, right? So this is once again having no patient voice in the research and making assumptions around how you do your research. And we've known this, Dr. Tom Livey, who's now the Dean of Public Health at Tulane, he tells me this all the time. He's like, I've been talking about this since the 80s. You maternal and child health people do not want to listen to me. Okay, but so they did studies forever that you want to improve infant mortality, you need Black political power. When Black political power would tell people, we need more home visiting, right? So it's even work for everybody, all right? So what are our opportunities? What's missing from the care of Black women is the centered voice, validation of experience, and freedom to choose and be informed. Black women need respectful care that is free of implicit and explicit bias. It is the provider's responsibility to address these biases. To address the issues of maternal mortality, we need care that originates from and is defined by Black women-led organizations, practitioners, and community members. The same is true for this space, right? If you want to help Black women and help Black babies, you got to start with actually listening to what they have to say about what their needs are and follow their lead when it comes to making programs for them, when it comes to how you interact with them. The idea that we can professionalize our way out of it gets us into the inequities that we have today. And we're clear about that as a community. Black women's health does not belong to medicine, nursing, or public health. We all have something to contribute to our survival. That's how we live and how we breathe. We can't silo out our health into one or the other. That's why I love reproductive justice. I can be an OBGYN who listens to poets who are talking about reproductive freedom all in one day. That's how our culture works, and that's how we as a community move forward. Having a racial equity lens, when you're doing this work going forward, who are you centering and who are the people you really want to impact? And as you work on things for them, it'll grow out for everybody else. The example I would use is the American Disabilities Act. I'm sure you've probably heard this, but it's an important example. And the cutouts that we all use now on the sidewalks. It was built for the American Disabilities Act. We all use it. When we're moving groceries, if you're running, if you have a stroller. So choosing to center the people who are the most impacted is not pie. That doesn't mean that you won't get any more. It means that all boats will rise. We will all get better. If we could fix the way that Black women are treated in childbirth, everybody would be doing well, right? It would change our entire belief around how we are judged. And what's the role of nurse home visitors, or home visitors in general? We have some great opportunities. Physician contact is limited, right? We don't have the obligation of dealing with, we are, having the OBGYN in the office. You're there with them alone. You don't have us in the way. You are a lot of times their first clinical point of contact. You see their home environment. You're building a personal relationship. You are building education and empowerment. And what are some of the challenges? I know curriculum is a challenge because, as she mentioned, I ran some, right? Are we including mom? Is it just about baby? Do we realize the wrapper is important? Do we have any things around trauma-informed care? Do we have any things around ACEs? Are we talking about culturally congruent care? And then so really, how many people who work with you come from the communities that you're actually working? Very rarely have I seen that happen. These are some useful resources. I'm doing a racial equity, a root cause analysis, looking at your 5 whys. You can do that, hopefully, in your groups. Right now, we're doing Mothers' Heroic Voices Driving Birth Equity. American College of OBGYN is our subcontractor. We've interviewed Black women around what respectful care would look like, and now we're going to test it in other populations and really build a culture of respectful maternity care. These are our kindred partners inside of the Black Mamas Matter Alliance. There are about 60 of us. These are grassroots organizations or researchers who work, some of you in CDC and other places, and they are a great resource if you're really wanting to do this work. This is, we wrote a black paper, not a white paper, called Setting this on the Black Mamas Matter Alliance. These are our research principles, decolonizing research is what we call it. It's also on our website for Black Mamas Matter Alliance. And then this is my last slide, because I'm out of time. So in my favorite book, Ibram Kendi talks about 3 groups, segregationists, assimilationists, and anti-racist. He follows several people, and one of the people he follows, this is a thick book. He won the American Book Award, so it's got all this data. It's mind-blowing. It's a really important book. And he follows Abraham Lincoln. I love Abraham Lincoln. Y'all love it? I mean, he freed the slaves. Thank God for Abraham Lincoln, right? But he was a complicated man, right? As we all are complicated. So near the end of the war, he brought in the top 5 Black people to the White House. You can picture it. They're like, yeah, we come to the White House, we're winning, right? And he was like, hey guys, I got $3 million. Liberia says you can come back. Why don't you just take your people and go? And they're like, because we've been here for 250 years, building all this stuff for free. We think we're gonna stay. And he was like, but guys, you're being so selfish. If you would just leave, the war would end. Because the truth is, although Abraham Lincoln was a good and moral man and he believed slavery was bad, he believed Black people were broken and we had served our purpose, we had built the country, and it was time for us to go back. So if you're in this room and you're doing home visiting or doing this work and you believe you're doing it to save Black people because we're broken, we don't need you in this work. We need you to be actively anti-racial. Yeah. Thank you. Yeah, we need to be actively anti-racist so that we're all even, we're all equal, we're doing this together, and we all need each other. So thank you. That's it.
Thank you.